Yes, please write them down and we'll come back to them. Oh, I have it right on this. Yeah. Okay, so for outpatient settings, this is quite different. There's a lot to go through outpatient, so I kind of honed in on one topic that is kind of my personal favorite, which is women's health and epilepsy. There's a lot to talk about here. I have 3 cases, and they highlight different components of treatment of women in epilepsy, women with epilepsy. So the first case, we have a 23-year-old female who presents to your clinic after having new onset seizures. She's had 2 generalized tonic-clonic seizures within the past 3 months. And in retrospect, she does report some myoclonic jerks through her teens, which have persisted. She has some myoclonic jerks still. She has a positive family history of epilepsy. So kind of what are we thinking at this point? Even before the EEG, we're thinking, does she have a generalized epilepsy? She's having myoclonic jerks, a family history, and generalized tonic-clonic seizures, and I should say without an aura. So we're kind of thinking clinically, does she have a generalized epilepsy? Maybe even possibly had JME, juvenile myoclonic epilepsy, in her early years. So her EEG did confirm she has generalized polyspike activity and generalized spike and wave activity on her EEG. So the questions when we see these women with epilepsy coming to our offices, first thing is, what seizure medication do we choose? Folic acid, we know that that's important. What dose are we prescribing, and what counseling is needed specifically for this patient population? So first I'm going to go into the seizure medication selection, and there was a recent publication, 2024. It's the practice guideline from the AAN. The title is listed here, and it's based on a systematic review studied through August 2022. So this is kind of our most updated information that we have in place in the AAN guidelines. So I do have kind of verbatim here the guidelines listed by the AAN in different orders based on the points I'm speaking about. So first listed here, so clinicians should engage in joint decision making, and this acronym stands for people with epilepsy of childbearing potential. So if you see that later on. So joint decision making is very important in providing that education of the options and potential risks associated. And then when treating this patient population, we should recommend ASMs and doses that optimize both seizure control and fetal outcomes should pregnancy occur. And this is probably the most important part of this paragraph, at the earliest possible opportunity preconceptionally. So this conversation, ideally should be happening if you're starting any women of childbearing potential on seizure medications after menarche. So after they go through that transition, they should be aware of the risks and be counseled on this topic, even if it's not relevant to them at that point in their life. And that's how I word it to my patients, as I say, you might not be thinking about pregnancy now, and I don't know your standpoint on pregnancy, but I'm going to give you this knowledge so that you know it moving forward. So clinicians must counsel their patients with epilepsy that the birth prevalence of any, and this is major congenital malformation, in the general population is approximately 2.4 to 2.9%. So this is a reference. So women without medications, healthy, this is their potential of a major congenital malformation occurring. And so then we have these other references to seizure medications and varying on the level that they were studied. So, as most of us are familiar with, lamotrigine and levetiracetam have been studied pretty well in pregnancy. We have quite a bit of data on that. So the comparative risk to a population off medications, it's only a very, very tiny higher risk than a woman off of medication. So this is kind of how we can break it down to our patients and explain that risk. As you can see here, and same with oxcarbazepine, but valproic acid, that's one of our highest risk during pregnancy. That's 9.7%. So we can kind of provide these ranges to help them gauge the level of risk going forward. So now we're going to pause and take a question before we get into the details. Which anti-seizure medication is associated with the correct potential teratogenic effect or pregnancy complication? So we have a few combinations here. So which one is associated with the correct potential teratogenic effect? And this can be a difficult question to remember all of these potential effects of seizure medications. All right, so here we go. We have a little bit of a competition going on here. So we can even just hop to the answer. Like I said, it's difficult to remember all of these, honestly. So the answer here is actually phenobarbital causing significant cardiac malformations. And I put that in there because that's not one I commonly think of. So I'm sorry to everyone, but I thought that was an important point to highlight, and it's actually highlighted in the guidelines. So that's why that's here. Zonisamide, there's no data to suggest oral clefts, but that can be, we associate zonisamide sometimes with topiramate, and topiramate has the clefts associated with it. So phenytoin, so the urogenital malformations, actually valproic acid has a significant risk of those. And for small for gestational age, the guidelines highlight topiramate and valproic acid for a risk of small for gestational age. Also, I think there's some evidence with zonisamide to consider. And then for neurodevelopmental effects such as autism and lower IQ, we have definitely evidence on valproic acid, but also more evidence to suggest topiramate involvement with that. So here's the answers to that question, and we're going to go into this a little bit more. So obviously what should be avoided, very commonly known to try to avoid valproic acid if at all possible. I say this, but it can be difficult to sometimes avoid valproic acid. Some people with generalized epilepsies, I've had some patients only respond to valproic acid. So it's sometimes easier said than done at the end of the day, but we try our best to avoid it. So we avoid it to minimize the risk of these major congenital malformations and neural tube defects, and to reduce the risk of these other things here. So urogenital renal malformations, small for gestational age, and poor neurodevelopmental outcomes like autism spectrum disorder and lower IQs. So valproic acid use specifically is likely associated with a decrease in full-scale verbal and nonverbal IQ when compared to these other medications here. So carbamazepine, these are abbreviations here: carbamazepine, gabapentin, lamotrigine, levetiracetam, phenytoin, and topiramate. So we have found that commonly in our data here. So what else should we try to avoid? And it's topiramate. So there's more and more evidence coming out on topiramate and its effects. So the one that's very commonly known is the oral clefts risk, but also small for gestational age is a risk. And there is some data to suggest the risk of neurodevelopmental disorders, particularly at doses greater than 100 milligrams per day. So, and then also to try to avoid phenobarbital for risk of the cardiac malformation. So that's specifically listed in the guidelines here. So clinicians, so what should we consider for treatment? Those are the ones we should avoid. So what should we be leaning towards? So clinicians must consider, this is listed in the guidelines, using lamotrigine, levetiracetam, or oxcarbazepine when appropriate. And so these three have some of the most supportive evidence and best safety profiles during pregnancy. obviously you can be limited in certain situations. Some people have really bad mood side effects to levetiracetam or Keppra. Severe depression, they can't do it. Sometimes then we hop to lamotrigine or Lamictal, and that can help mood, but sometimes you got a woman with a rash, and then you're kind of up that creek. So oxcarbazepine or Trilaptol is great, but it's not ideal in generalized epilepsy. It's a more narrow-acting medication. It's not our first go-to in a generalized epilepsy. So those are some challenges, but what we should try to think of first, and then the rest of the medication. So we should also counsel that there's limited data on certain medications that we just don't know. And this is important to know of because you get patients on a certain regimen and they already have that list and prior seizure medications tried and used, and they've failed all of your go-tos that you have. So it's important to know which ones that we have limited evidence on and to kind of proceed with caution. And the ones that I'll highlight here, lacosamide, perampanil is on this list. Cenobamate, also called Xcopri, is on this list. And one of our newest medications that we don't know a lot or anything about in pregnancy. So important to know this list of medications. So I wanted to show you this table to tell you that it exists. I'm not going to go through it, but it's a very helpful resource when looking at your patient's seizure medications and figuring out that risk and trying to explain it to them. So this is the medication. It lists it out in monotherapy versus polytherapy, and it tells you the prevalence per 1,000 of any major congenital malformation. So you can refer to this list to kind of gauge that level of percentage. Like, for example, lamotrigine is listed here, 30. So that's what we heard before, at 3%. So, and then it kind of tells you the level of evidence on the side, the difference in prevalence between monotherapy and polytherapy. So you can kind of get more information from this table. In general, there's higher risk the more seizure medications that they are on, and you can see that with the prevalence listed here with polytherapy. So this is the rest of the table. It's just a nice resource to be aware that it exists to resort to. So now this is another tough question. What dose of folic acid do we prescribe? So in the guidelines, based on all of this evidence that we have, clinicians should prescribe at least 0.4 milligrams of folic acid supplementation daily preconceptionally and during pregnancy to any women with epilepsy to decrease the risk of neural tube defects and to improve neurodevelopmental outcomes. So it's not just neural tube defects, it's also to lower the risk of autism and cognitive consequences to the seizure medication. Clinicians, and then we should encourage adherence. We should tell them why they're on folic acid. Sometimes I get women, say, why do you take folic acid? Tell me about it. And they say, it was given to me. I think it's for the seizure medication, and I break it down to them. And I think it's important for them to understand why, so that they actually take it and they view it's just as important as taking the seizure medication. So really taking time to break that down to them. And so this is just to highlight these points here. So it's possibly associated with better neurodevelopmental outcomes, reduced autistic traits at 3 years, higher IQ at 6 years. And then, so what are the risks of folic acid supplementations? Because the guidelines say to give at least 0.4 milligrams of folic acid, and that's easily in a prenatal vitamin. So a lot of us prescribe more than that. So what are the risks of prescribing more than that? And it's inconclusive, but some of you may have heard of a more recent study So one study of 27,000 children born to people with epilepsy with preconceptional folic acid greater than 1 milligram per day was associated with a 0.9% absolute increased risk of childhood cancer prior to the age of 20. So some of you may have heard this study, and our group definitely had a big conversation about it. Sub-analysis comparing folic acid doses less than 3 milligrams per day to women without high-dose folic acid was not significant. So, really we have a lot of variable evidence on this. Our group talked a lot about it, and we don't have, enough evidence to support a significant risk of childhood cancer. We need more studies on this, more investigation. So the ranges of folic acid given tend to be, anywhere from 1 milligram to up to 4 milligrams sometimes. So it's really based on clinical practice at this point and what your mentors have taught you and how to proceed forward. I would say, in general, the guidelines say at least 0.4 milligrams per day, and that's easy to obtain. You can prescribe 1 milligram, and that's easy to get past that 0.4. But in clinical practice, people do it different ways. If they're on a lower risk seizure medication, you may see providers prescribing 1 milligram per day. So let's say they're on lamotrigine or levetiracetam, they may take 1 milligram per day. If they're on a higher risk seizure medication, preconceptually, providers may prescribe 2 milligrams per day, like if they're on valproate or if they're on topiramate or something, or polytherapy, multiple seizure medications, may prescribe 2 milligrams per day. If they're pregnant and on a high-risk medication, the way that our group, clinically practices is still to sometimes give the 4 milligrams per day. So it's very variable on practice, and we need kind of more data on the exact dose. What would be the most beneficial and the least risks of anything developing from the folic acid. So hopefully more to come on this, but most importantly, just at least some folic acid in their system. All right, here we go. So what other counseling is needed? So when treating women with epilepsy, definitely contraception comes up. And so I'm going to use some examples. What do we do if a woman is on levetiracetam? What should we counsel them on contraception? So when we think of levetiracetam, when thinking of contraception, we're thinking of interactions mostly. So the efficacy of the seizure med, is that affected by the contraception, or is the seizure med affecting the contraception of efficacy? So both are important. And so levetiracetam and other agents included here are non-enzyme inducing agents. So these are liver enzymes. If you're inducing an enzyme, you can affect other, inducing or inhibiting, you can affect interactions between medications. So basically, I list this population first because really anything goes with these medications. With levetiracetam, lacosamide, zonisamide, there's no major interactions. There's no major enzyme, changes. So anything goes. You have your IUD options. You have your progesterone-only intramuscular injection. You have the subdermal implants, and then all these other options listed here, OCPs. So anything goes with these agents. But then what if you use something like lamotrigine? So lamotrigine, and lamotrigine is actually a little bit unique because the oral contraceptive pill can actually reduce the lamotrigine level itself. So that's something to keep in mind. But these are considered weak inducers. So topiramate specifically higher than 2 milligrams per day, and other agents like felbamate, clobazam, or known as Onfi. So these agents, with it being weak inducers, The intramuscular injection, the subdermal implants, and the IUD are still acceptable, but as listed here, these other agents like vaginal ring, transdermal patch, some progesterone-only OCP, those become more limited, or the OCP in general. I will say with, sorry, I went backwards. I will say with lamotrigine, we do have women on the OCP. It's just you have to really tightly manage the lamotrigine level, and if they come off the OCP, the lamotrigine level could change. So it's just a matter of monitoring that level as well. And then to go forward, what if we use something like oxcarbazepine? That's a little bit different. So some agents are strong inducers, and this can definitely change the efficacy of like the oral contraceptive pill. So these strong inducers are phenobarbital, phenytoin, carbamazepine, primidone, oxcarbazepine, and perampanel. So these you have to, if they're on the oral contraceptive pill, you have to counsel them that the efficacy of it might not be up to par. So to try to use another form of birth control, that it might not work. So really in these patients, we emphasize IUDs, and the injection as well could work. But just to proceed with caution on other or contraceptive agents. So all important things to discuss with this patient, for example. This is going back to our case. So options for this patient, we think, okay, she does have generalized epilepsy. It's confirmed by EEG. So the first two agents, as stated by the guideline, we want to think of lamotrigine and levetiracetam. These cover for generalized epilepsy, good choices. If for some reason she can't tolerate them, maybe she gets a skin rash on lamotrigine, maybe she has really bad depression, can't do levetiracetam, then these agents are also reasonable to consider in a young woman. Zonisamide and lacosamide, there's some, at least some evidence about them. There's not enough, but there's no major red flags. With zonisamide, we do have to monitor for the growth, the fetal growth. So zonisamide or Zonegran may also help with their migraines or weight loss. So these other potential side effects may come in use at times. Okay, so there's another case here. This is one of my clinic patients, so a 20-year-old female with a history of well-controlled generalized epilepsy. That's what we always like to hear. With generalized tonic-clonic seizures and myoclonic seizures in the past, present to clinic to establish care. So she's 20 years old. Her last seizure was in 2018. Woo, we got it made. But what is she on? Okay, she's on valproate, ER, 1,000 milligrams daily, and she is taking her folic acid 2 milligrams daily. And by the way, I'm 22 weeks pregnant. That's what I was thinking when I met her. So, what did we get into now? So we have a woman already on valproate coming to you pregnant. What do you do? What do you do? Do you change her off? Do you keep going with it? Where should we go from here? She's already about 5 months pregnant, but even if she was earlier in her pregnancy, what would you do? So this is the data that we have on her. So her last EEG, because she's been well controlled, her last EEG in 2019 did show some generalized spike and wave activity. She hasn't had a more recent one. Her valproate level was 54, so kind of on the lower end. She's well controlled on that. And then she had an anatomy ultrasound that was normal. That's good. First good step. So what do we do? So now we're going back to the guidelines. What do the guidelines tell us? So clinicians must minimize the occurrence of convulsive seizures, generalized tonic-clonic, focal, and then secondary spread during pregnancy to minimize potential risk to the birth parent and to the fetus. So generalized convulsive seizure activity can be very dangerous in pregnancy. So number one, we want to avoid seizure activity during pregnancy. Okay, so our guidelines also say once I'm just, for ease sake, I'm going to say women with epilepsy, is already pregnant, clinicians should exercise caution in attempting to remove or replace that anti-seizure medication that is already effective in controlling generalized tonic-clonic or such seizures, even if it's not the optimal choice. So you have to weigh the risk benefits. So when thinking of changing a woman who's already pregnant to a different seizure medications, the plus side would be to get her off of valproate, yay, but the downside of it is to transition someone to a different seizure medication, you have to overlap a medication for a couple weeks. So now they're on 2. Now they're not only just on valproate, they're on something else in addition to it while you wean off the valproate. So now you have polytherapy for a little while. So that increases the risk even more. And then there's no telling how that woman will respond to that new treatment that you choose to prescribe. So you don't know if they're going to, some people who respond to valproate are very particular about their valproate. They do well on it, and we don't know how they're going to do on something else like levetiracetam. So the guidelines are saying here to exercise caution in that and even consider keeping them on that agent even though it's undesirable. And that's the data that we have right now on this topic. And so then moving on to the next point here. So clinicians should monitor ASM levels throughout pregnancy, guided by each individual seizure medication. I know Susie might go into that a little bit further, so I'll leave that to her. I think I touch on it a little bit here. So clinicians should adjust the dose in response to 1, decreasing serum levels throughout pregnancy, or 2, worsening seizure controls. So we shouldn't hesitate to give them more seizure medications if they need it, because the seizures themselves are also at a risk for pregnancy and the woman and the baby. All right, here are more guidelines here. So what monitoring do we need during pregnancy? So to enable early detection and timely intervention of major congenital malformations, obstetricians should recommend fetal screening for major congenital malformations. So this, seems obvious. We want them to be monitored for these things. In general, you should refer these patients to a high-risk OB. Make sure their OB has your contact number. Give them your phone number. Get in touch. That's how I practice. I make sure to collaborate with them on their care, just so that if something comes up, they can easily get a hold and work together on their care. And then we should also, the guidelines specifically point out phenobarbital. If they're on phenobarbital, that cardiac investigations should occur of the fetus. And then we should monitor fetal growth. And the obstetricians know this. They know a lot of them are familiar with some of our seizure medications. Some of them are not. So just to highlight different components to them, for example, zonisamide, highlighting that fetal growth is important, then they'll also keep an eye on it along with you. So what did we do with this patient moving forward? So she was quite far along in her pregnancy. We did opt to continue the valproate. We had a very long conversation. It was quite late in her pregnancy, but even if it was earlier, it's that risk of the titration and switching to something else that you have to be very hesitant moving forward. She continued on folic acid. The way that we were practicing at that time, I did increase it to 4 milligrams per day due to the high risk medication that she was on. We did update her EEG. It did look okay, which is great. And she established care with a high-risk OB. And obviously was educated about the risks moving forward, and educating about breastfeeding, also very important moving forward. So an update on her. So she had a healthy baby boy, no malformations or anything. It was a very successful delivery. She, at 6 months postpartum, we got her off of that valproate. Goodbye. And she did great. She didn't have any breakthrough seizures or anything like that. She was transitioned to levetiracetam and doing well. So almost 2 years, the baby, I just actually recently heard an update that baby may be showing some signs of autism spectrum disorder, so something that she is monitoring with her pediatrician moving forward. All right, so moving forward, and I know I mentioned it for 1 second, but breastfeeding counseling is very important as well. I wasn't going to elaborate it here, but just in general, there's varying risks with the seizure medications and their effect on breastfeeding. In general, I will just take a moment to say the baby is getting a lot less seizure medication through the breast milk than in utero during the pregnancy. So in general, breastfeeding is encouraged with women with epilepsy, but there's certain side effects to monitor for depending on the agent in the baby, and that's medication specific. So just working with a pharmacist or looking up that information, very important. Okay, so all right, last case here to highlight a couple more points. So a 19-year-old with a history of, for some reason I was gravitating towards generalized epilepsy for this talk. So well-controlled, and I think it's because there's more limited treatments. So well-controlled generalized epilepsy with generalized tonic-clonic seizures at the age of 3 to 4 years, absence seizures, last witness at 11, and she presents to transition care from peds to adult. And she's 8.5 weeks pregnant, unplanned. So this is one of my patients as well. She was on topiramate, 250 milligrams BID, and folic acid, 1 milligram daily. So once again, a case of someone coming to you already pregnant on a less desirable seizure medication. Her ambulatory EEG at home showed 24 hours, showed 1 year ago, infrequent generalized spike and wave complexes. So how do you approach this? It's very similar to the valproate situation. We did opt to continue the topiramate at that point in time, and she continued that throughout pregnancy due to the risks we already talked about. So this is the data that she had. Her pre-pregnancy level was around anywhere from 11 to 16. You know, seizure medication levels, which Susie is going to touch on, it's very particular. Timing can matter a lot. So the range can be a little bit big, but her levels were 11 to 16. So as with the previous case, I won't elaborate on this. We did the education, we counseled, we continued with the topiramate. We opted to repeat an EEG just to see how things were looking, and she established with a high-risk OB. So at 25 weeks, so this is nearing the end of the second trimester, her topiramate level was 8.8, so she was at a range of 11 to 16, and now she's 8.8. So second trimester, she did drop. We increased the dose by 50, so 250, 300. She was on 250 BID before, and her recheck level was 10.9. So, okay, good. We're back in her kind of regular range where she normally was. At 37 weeks, so in her third trimester, she had the ambulatory EEG done, and she did have increased burden of epileptic discharges. So her spike wave activity was more frequent, and it happened to correlate with a lower level. So we didn't kind of plan for that. We were just doing an EEG to check in with things, but it happened to correlate with a drop in her level again. So we did increase her to 300 milligrams BID, and her dose, her level came up. She did deliver a healthy baby boy. She opted not to breastfeed. That was her personal choice. And she, to this day, continues on 300 milligram BID for now. When considering when to reduce back to the regular level, it's dependent on the seizure medication, but you have to keep in mind that these people with epilepsy may be a little bit stressed at the time. Immediately postpartum, there's sleep deprivation, there's stress, there's emotions, and all of these things can contribute to a seizure trigger. So you don't want them having seizures right after they give birth. So in general, for this case, I kept her on the higher dose postpartum for a couple months, and we're rechecking things. We're rechecking her level in EEG because she had spike wave activity on that EEG. So before we immediately drop, we're looking at things, and then we may have a conversation about switching her to something else down the line to get her off of that. But for right now, she's continued on that during the postpartum phase. These are postpartum considerations. So the breastfeeding I briefly touched on, sleep deprivation, stress, mental health, very important during that phase. Okay, and then I will just highlight here. Actually, Susie, you're going to be highlighting this, right? Okay, so Susie can elaborate, but the Monid study listed here studied 326 pregnant women, 104 controls. And this is investigating a variety of components of, it's one big study, and they publish, they look at different things within this population of patients. So the study that looked at ASM levels, so these levels decreased, ASM levels decreased by up to, they're varying on how they function throughout pregnancy. Lamotrigine is the most dramatic. It drops, and you really have to chase it to keep up with it. So this is just, why we check levels throughout pregnancy monthly, keep an eye on things because they can drop on you. And a lot of this we don't know exactly for some of these seizure meds, so checking in on them is very important. This study found no significant changes for unbound carbamazepine and the topiramate and the carbamazepine metabolite. So although for topiramate, I have it somewhere in here, although not significant, topiramate levels were markedly lower in the third trimester compared to the postpartum period. So for my personal patient, she did drop in the end of second to third trimester. So we just need more data on these things. That's why we monitor. Let's see here. And lamotrigine was lower in the second and third trimester compared to the first, but really lamotrigine can really start dropping fast. So, but this is what this study by Pennell et al. Highlighted here. So that kind of concludes the outpatient talk focused on women's health and pregnancy. So women's health and epilepsy. Thank you.